Hello. Tonight we're doing a sarcoidosis Q&A. So welcome. My name is Abigail Mangum, and I am the project coordinator here at Life and Breath. And our primary goals are to offer the sarcoidosis community effective tools to track their journey, to provide a nurturing environment, and to build more awareness for sarcoidosis. So patient hope and empowerment is what we are about, and we're super glad to have you here tonight. What we do, we have this monthly speaker series, and you can find all of our replays from the last few years on our YouTube channel, Life and Breath Foundation. We have a Life and Breath Scholar Physician Education Program where we are hoping to encourage resident physicians to do more research and study in sarcoidosis. We have a patient support group and the My Life and Breath Planner, which is a sarcoidosis patient and expert designed roadmap. Yes, and I'll put a link where you can request one of those. It has showing you on the camera what it looks like. So tonight we're doing something a little different. We have Dick Hewitt here. He is going to be our host. He is a sarcoidosis patient, and he has had sarcoidosis for 42 years. Yes, long time. So he knows a lot about this and always says that he is also learning a lot about sarcoidosis. And he and his wife, Pat, are actually the hosts and leaders of our bi-monthly support group. So on the second and fourth Thursday of each month, we have a support group for patients by patients that is not recorded. It's just a chat section. So I will post in the group where you can register and join us with that. But tonight, Dick will be our host. And we have Dr. Carr with us as well. She is on our clinical advisory board. She is the program director for the Internal Medicine Residency, as well as the Pulmonary and Critical Care physician at Greater Baltimore Medical Center. And she is a sarcoidosis expert, knows a ton, has been super helpful to the foundation. And I'm super excited to have her here to do this Q&A tonight. So let me read our disclaimer. This webinar will not give medical advice. No doctor-patient relationship has been established by talking with Dr. Carr during this meeting. Our speaker does not know your medical background and therefore cannot give any specific medical advice. Speak with your doctor before acting on any of the information you hear this evening. Okay, so like I said, we do have a lot of questions pre-submitted, but if you have questions during the webinar, please go to the Q&A and we'll be watching the Q&A specifically for questions about what we're talking about. And then the chat is just for all of us to go. So welcome chat, welcome Dr. Carr. Thank you so much for being here.
Oh, it's such a pleasure. Thank you so much for having me.
Wonderful. And Dr. Carr, I agree with that. Thank you very much for taking your time out this evening to do this for us. Welcome, everybody. Some of you know Pat and I very well from the support group. Others, we're glad you joined us this evening. As Abigail said, I'm one of the veterans, sarcoidosis warrior, but I've been on this journey with my lovely bride, Pat, for 42 years. So sarcoidosis, that leads me, Dr. Carr, right into the first question, and I've got to kind of editorialize on it. And just so everybody knows, we had over 50 questions submitted. Dr. Carr and I and Abigail have reviewed them all. We can't certainly get to all of them, and some of them, if you go to the Life and Breath Foundation page and to the webinars, you'll find some of the answers to the questions asked. But Dr. Carr, right out of the bat, can I live a normal life with this disease, and is it autoimmune? And let me just qualify again, 42 years, but I won't call my life normal. But yes, you can live. Dr. Carr, what about that? Can we live a normal life, and is it an autoimmune disease?
Well, so I'm going to take those in two different parts because they are two separate questions. First of all, yes, you can absolutely live a normal life. And I think Dick just clearly said what is normal. So everybody has their own definition of normal, but you can lead a healthy life and a symptom-free life, which I think is probably what people think about, right? You can have a good quality of life if the disease is going to be different for every person. So that's part of what we talk about. So in terms of the autoimmune piece, it is not in a medical term, it is not considered an autoimmune disorder, but it really does seem like it acts like an autoimmune disorder. In a sense, it's part of your immune system that's kind of ramped up. So, and it's affecting itself, so therefore it's kind of autoimmune. But it is not classified in medical terms under an autoimmune disorder. But you can think of it that way for sure. And so that's one of the reasons why a lot of the treatments are directed towards suppressing the immune system, kind of quieting it down. Okay, hope that helped.
Very good. Thank you. Hand in hand with that, the one that everybody is always curious about, I know I certainly am after 42 years, and we'll put a couple of questions together. What new knowledge about pulmonary sarcoidosis has been discovered in recent research studies, and what are the newest treatments? Again, that's a two-part question, but what's the latest, Dr. Carr, on pulmonary sarcoidosis?
So I think, unfortunately, we have not made tremendous progress in terms of still trying to identify what triggers sarcoid. We know that there's a genetic component to it. We are strong believers that there is something in the environment that probably activates the cascade. But we still just don't actually know exactly what triggers sarcoid. We do believe that it is something that is from the environment because the skin, the eyes, and the lungs are the three most commonly involved organs, and they are the most external facing organs that we have. So we have still a lot of work to do in that arena to try to figure out the exact causes. So what they are really focusing on in the research is, number one, clinical trials. So trying to figure out which medications are most effective. There's actually a trial on what dose of prednisone is the most effective to actually cause remission. So, or remission, yes. And so I think that's where we're going to see most of the growth in the research for what's coming down the pike. There's quite a few studies actually looking specifically for cardiac sarcoid, looking at what type of imaging is best, whether it's a cardiac MRI that is better than a PET scan, whether you need both, whether you need one. So I think we'll probably, it takes a long time for the research that's being done, either in the lab or these clinical trials, for it to actually get to the mainstream public. But I'm hoping that we should see some ongoing results in the next 5 years, that we should have some better updates in terms of better guidance. Because right now we practice what we know best because we're constantly looking to see if anything new is coming down the pike, but we still have sort of a kind of a formula, but not a great formula. Everybody's got different recipes on how to do this.
Wonderful, thank you. And Dr. Carr, in that answer, you gave me a great segue to the next one, the one that comes up over and over again, certainly in our support group, and I know myself personally. First line of treatment, and when people talk first line of treatment, we hear the word prednisone, we heard methotrexate. I know, and again, in that conversation of prednisone, being a person with diabetes, wow, does prednisone mess with blood glucose? So, Dr. Carr, what treatments, prednisone, methotrexate, what is there out there, and even what new treatments? What's first line treatments? What do we do with sarcoidosis?
Okay, so I think you raise, just in those series of questions, lots of really important issues. So today, the standard of care 100% of the time is start with prednisone. And the starting dose is what's a little bit tricky. So really it's anywhere between 20 to 40 milligrams. Most of the time you can get away with starting with 20 milligrams, which we call low dose, believe it or not. And so 20 milligrams of our body naturally makes the equivalent of prednisone, right? So our body actually makes cortisol, which is a steroid derivative. And the amount that our body makes every day is considered to be roughly about 7.5 milligrams. And so when we're talking about taking 20 milligrams, it's not that crazy. But the havoc that it can wreak, for sure, and it causes all sorts of problems, right? So somebody who has never had any problems with their sugars can develop diabetes. So you can actually get steroid-induced hyperglycemia or diabetes. And so that's just one of the problems, right? There's weight gain. I mean, every single patient of mine has gained weight except for one, but that person was very, very conscientious and did a very aggressive exercise diet and exercise routine. Not even really the exercise part, but mostly the diet part, to really try to combat it. But otherwise, generally speaking, you're going to gain weight on prednisone. And then there's all sorts of other things. It causes hypertension. It can cause mood swings. It can make you really feel very elevated, have difficulty sleeping, and I can go on and on and on. So we will pretty quickly, if you become intolerant to the steroids, within like 3 months of being on steroids, we'll pretty quickly decide that you need to switch to the next level agent, and that would be methotrexate. There are quite a few drugs that are in that same, what I'll call class of drugs, but methotrexate, leflunomide, mycophenolate mofetil, azathioprine, those are just a few that are sort of what I call second tier. They also have side effects, but certainly less sort of overall imminently, like a daily toxic, the way steroids can make people feel. So, so that's sort of the next choice. And sometimes people have to be on both. And a lot of it depends on what organ's involved, right? Like, you know, how severe is the disease? Do you need 2 doses, 2 medications? So if we find ourselves in a situation where we need 2 medications to keep you controlled, that's when we can actually consider going to the third tier, which is actually what I would call the injectables. Right now, they're all injections. Some of them are infusions and some of them are injections that you can do at home. They range anywhere from weekly to every 6 weeks. And they're TNF alpha inhibitors. So they are a completely different type of immune suppressant type medication, very, very effective. So that whole class is where we're really starting to see a lot of research coming out and trying to get and developing and seeing which of those medications that exist, because there's probably, I don't know, maybe about 7 or 8 of them right now, maybe, and more if you think about other parts of it, but those have a lot of potential for our patients. So that's sort of the stepwise. So unfortunately, prednisone is the first place to start. Many insurance companies in the United States will not pay for anything else if you have not tried prednisone first. And they definitely will not cover TNF alpha inhibitors because they can be super expensive. We're talking like on the order of thousands of dollars. Those will not be covered unless you have gone through tier 1 prednisone, tier 2, one of the methotrexate family, and then finally down to that. So, and there are other drugs that are very toxic as well, but that are very effective for very severe disease.
Certainly are. Thank you very
Right.
much.
I hope that wasn't too much.
No, no, not at all. And just as a footnote, I've told both my pharmacist and my pulmonologist, anybody prescribing prednisone should be also handing that patient a blood glucose meter.
Good
Whether they
point.
have diabetes or
Absolutely.
not, they ought to
Yeah.
be learning what blood glucose is.
Yep. Yep.
Yeah, I could almost look at my continuous glucose monitor and put a stopwatch on blood glucose from prednisone, but we'll move on. Along that area, one of the curiosities that we get a lot, there's this alphabet soup. You know, we go in for our pulmonary tests and our CT scans and everything else, but then it comes up on my chart, and there's this alphabet soup of FVC, FEV, PEF, DLCO, all of these things. What are all these diagnostic things that come back, and what are we looking at when we see those?
Well, that's a topic in and of itself that I'm happy to give another talk on, but that's actually called pulmonary function testing. And pulmonary function testing is a really, really reliable way to have somebody give us very specific numbers on what the function of your lungs are. So what we look for sort of 3 main categories. One is what we call spirometry, which is either where you have obstruction, so obstructive lung disease, or you have restriction. So generally speaking, in sarcoid, we're going to see restriction if it's in the lung tissue. We see obstruction if it's in the airway. And so somebody who may have obstructive lung disease would be somebody you probably know who has asthma, or maybe even what we call COPD or emphysema. Those are all really obstructive lung disease. Restriction is more the scarring in the lung type thing. So we look at that. And then we look at lung volume. symptoms, which is the second portion of it. And that actually will tell us basically the severity of the restriction. So you can either have big floppy lungs with COPD and emphysema, or you have really tight lungs because you've got some scarring in there. So we use those numbers to help us with that. Then the last one is actually how well do your lungs take oxygen from this dirty, filthy air, sterilize it, extract it, and put it into your bloodstream, where that's the whole purpose of the lungs, basically, right? And so that's called diffusion capacity, and it's known as DLCO on the breathing test. So we look at all of this stuff, and we monitor progression. We want to look at comparisons year over year. It can tell us a lot about the lung function. I have seen people with really terrible breathing tests, breathing tests that look like they have very severe disease, and they get almost back to normal with treatment. And, and then we can follow the breathing test. So it's not a super invasive test. And it's an easy enough test to perform. And then we can actually monitor things and pick up things early if we trend them over time.
Great, thank you. And while we're talking about testing and then, some treatments, and I know this is one that I find, it's very personable to me. Pulmonary rehabilitation. After 42 years with this wonderful condition, my pulmonologist, and I'm glad this question came up, asked that pulmonary rehabilitation, and in that same conversation is something that was new to me, the 6-minute walk. So pulmonary rehabilitation, what do you think of pulmonary rehabilitation, doctor?
So pulmonary rehab is actually fantastic for people who have advanced lung disease. However, the literature does not support that it's actually going to necessarily give anybody major benefit unless you have COPD. So but that said, patients who have interstitial lung disease, and I'll throw sarcoid into interstitial lung disease because we're clearly talking about pulmonary sarcoid and not the other things. If you've got pulmonary sarcoid, certainly you can benefit from doing a pulmonary rehab program. It's like if you have a shoulder problem, you go to see physical therapy and they can actually fix it for you over time, right? And so pulmonary rehab is great because it teaches you that they'll do like breathing exercises with you, help you try to figure out how to maximize your breath so that you can actually accomplish more. They will do physical training with you so that you actually work on muscle strengthening and cardiovascular exercise in a setting where they can actually monitor your oxygen levels and make sure that you're maintaining enough oxygen to be able to do those things safely. The concept of a pulmonary rehab program is you do it for 6 weeks and then you take it home and you finish, you keep doing the stuff at home by yourself. Insurance companies generally cover it, but again, mainly for COPD or somebody who's already on oxygen. If you, Dick, no offense, you look super healthy to me. I heard you say something before about how you're running marathons. You would not benefit from pulmonary rehab.
Right.
That just does not make sense, right? Because you're already achieving such a high level. But there definitely are people who are struggling and would benefit from not only the education, but also the actual individual training. They actually now finally, COVID, something good came from something bad, which is during COVID, pulmonary rehab places shut down all across the country. And so, or world probably. So they actually started to create some online pulmonary rehab. So for people who don't live anywhere near a pulmonary rehab center, there are actually online versions now, which is great. We all know that online is not as good as in person, but it certainly is a great option for people who don't have access. The other question you asked was about 6-minute walk. So I'm happy to maybe pause and see if any questions are coming in about what I'm saying so far before I jump into 6-minute walk.
Sure, go ahead with the 6-minute walk. We do have some questions coming in, but while we're talking about the general rehab, yeah.
Okay, so 6-minute walk is actually related to the pulmonary function testing that I said before. It is done very specifically in a lab where we are measuring how far you can walk and what happens to your oxygen levels when you walk. A true 6-minute walk test is you basically walk as fast as you can for 6 minutes, and then we check your oxygen levels before, we check it after, and really what we're focusing on is the distance you cover. And so it's really sort of your function, like how functional are you, and at your shortness of breath scale when you're doing that. So most places, and my lab will do this, is that we actually really do it more as an exercise challenge to see if you drop your oxygen when you're walking. And so, because that's actually potentially more important for most of us. 6 minute walk is used as data scientifically for pulmonary hypertension, less so for sarcoid. It's not really been validated as like, oh, if a person only walks this, what does that mean? We don't really have that for sarcoid. So I wouldn't worry too much about that. I think most of the places are really doing it to just challenge you. And I encourage you, when you do that walk test, that you walk as hard as you can or as fast as you can, because you want to try to mimic the real world. And, you know, walking on a flat surface in an office is not at all the real world. It's not stairs, it's not an incline, you know, so you kind of want to be able to push yourself and see what your needs are.
And thank you, Doctor. You did notice that doing marathons was a number of years ago. I'm still on our local marathon committee, but I'm not running marathons right now. But thank you. The 6 minute walk
You
is.
look like you're running a marathon. You could run marathons.
Thank you. You know, and as we progress with that, well, quite a few of the questions relate to remission. You know, a question of my sarcoidosis has been dormant. Is sarcoidosis going to remission? A question even about cardiac sarcoidosis and remission. What kind of things is remission possible, and what kind of things do we look at?
So yes, remission is definitely possible. In fact, for people who need treatment, it is the majority of people that will go into remission. I don't want to get into the whole thing, but there's different types of sarcoid, some that don't even need any treatment. But if somebody does need treatment, generally speaking, we will be able to obtain remission. There are some people who will need to be on chronic treatment. The thing that we don't know is how long does that remission last? Like, we can't predict that. And that's, I think, probably the most frustrating thing. I have some patients who, wow, you know, as soon as they get on treatment, they're controlled, they feel great. And then they want to come off of the treatment, and they come off and they're doing great for a month, 2 months, and then they relapse, right? And so that's really hard for patients, I think. Definitely. But sometimes we get remission that can be, you know, 5, 10 years, and sometimes for life. Right? So we just never really know. So I do think that the goal should always be remission. And because, you know, I mean, what is cure? This is not cancer. So we don't need to think about it in the same way. So people can absolutely live with sarcoid in their body and have it have no significant impact on their life. So, and that's actually, maybe I can jump in with, that's sort of one of the main dictators of when we start treatment, right? So we really start treatment for people when they have, when it affects their quality of life. And why is that? Mainly because, as we talked about, prednisone can be so toxic. Like, why would you want to go on prednisone unless you actually had to? So we think about, like, you know, is your cough so difficult that you're not controlled with an inhaler? It's keeping you up at night. You go to the grocery store, people like walk away from you because they think you're sick and all this other stuff, or, you know, you can't sing at church anymore, things like that. So in those settings, you know, we would weigh the risks and the benefits, and we would say, okay, you know, the risks of taking the prednisone outweighs any of the risks of not, you know, to your quality of life. And then there are a couple of organs where if we see it, we will treat it regardless of symptoms. So mainly that's the eye, and then also the heart. So the eye, I know I saw a few questions about the eye. The eye is a really tricky place because there's 3 different chambers in the eye. There's the front part, which is you all see, and you can touch your eyeball. Well, don't poke it, but and then there's the middle part, which is sort of the globe, the center of the globe. And then there's the back part, which is the nerve. Part of the problem with sarcoid is that it can get to the back part of the eye, and it can make granulomas there, and you can't feel them at all until it's too late. And so That's one of the reasons why you have to see an eye doctor regularly, somebody who knows what they're doing with sarcoid so that they can look at the back of the eye and actually determine whether or not they see any of those granulomas, because if they do, you want to get treated regardless of symptoms. So that, and then the heart. And so, as you mentioned, cardiac sarcoid, if you've got it in the heart, you definitely want to get treated, because you don't, that's an organ that it's all or none kind of thing. So you don't want that none. So we definitely treat when we see sarcoid in the heart.
Wonderful. Thank you. And if I can just footnote your comments, Doctor, I know we want to make sure they go to an ophthalmologist. We emphasize that with our diabetes and our sarcoidosis groups, that make an annual visit to an ophthalmologist. Very important to
Yes, yes.
with
Not
all due
just an
respect to the
optometrist.
optometrist, the optometrist will get you a very lovely pair of fashionable eyeglasses, but you want to go to the ophthalmologist to see
Exactly.
truly see the back of the eye. Let's circle back a bit while we're talking about medications, and you mentioned prednisone again. It's come up in the chat and it's in the questions. Remicade, that's one we didn't talk about. What are your thoughts on Remicade, and how's that help with sarcoidosis?
Well, so Remicade is actually the trade name for a drug called infliximab, and infliximab is one of the TNF alpha inhibitors that class of medications, that's the injectables. Infliximab was actually the original medication that was discovered and used for sarcoid. So all of our literature on this really started in the world of rheumatoid arthritis and Crohn's disease, where they've been using this medication for a while. So we started using it, and it actually works. So infliximab is great. It's an infusion, so you have to go to the infusion center, and you can get it anywhere from every 4 weeks to 6 weeks, 8 weeks, kind of depends. There's different doses. So Remicade, I just say generic names. So infliximab is really a terrific medication. And when people get to that point where they need it, it seems to work great. Right now, it is hard to get covered by insurance. Infliximab is difficult enough to get covered by insurance because it also is about $8,000 a month. Some of the other medications that are out there, and one of them is adalimumab, and I can barely pronounce it. They all have really incredible generic names. But that one is actually an injection that people take at home. And while I would like to prescribe it weekly for my patients, insurance is only covering it for certain things, and uveitis is being one of them, and they'll do it every other week. So, but that patients, that is, first of all, a million times more convenient for patients, that they can actually get the medication at home and administer it themselves, or they can have it administered by somebody that they know that can do it. Anybody who's a diabetic and needs insulin, it's the same delivery mechanism. So it works really well, for increasing quality of life as well. So those are all in that class of medication. And I think over the next few years, we'll see more of that type of medication coming out.
Wonderful. Thank you. And we've got both in the Q&A and in the questions submitted. And again, we've kind of touched on it earlier, particularly in my own introduction, talking about the fact that I've got 42 years longevity with sarcoidosis. But people are always curious about life expectancy. And Doctor, I'll let you reiterate that. From what I know, in my experience, we don't necessarily consider sarcoidosis a terminal disease. Certainly people have passed away from sarcoidosis. My other life with diabetes, certainly people have passed away with diabetes. But I don't think, and Doctor, what's your thoughts? I don't think we look on them as terminal diseases, do we?
I'm really glad actually the way you said that was really very appropriate. It is, I think we will find that more people will die with sarcoid than from sarcoid, right? So I think I think we've, again, the majority of patients that I treat, actually their disease goes into remission. And so it is not even in that scenario, it's really not even a chronic debilitating disease. So Yes, there are definitely circumstances in which people can die from sarcoid, and very specifically from sarcoids. If it's in the heart, that can lead to a fatal arrhythmia, which means your heart just stops and there's nothing that we can do to bring it back, right? So that can happen. It is not the norm. I think people should not go into the saying, oh my gosh, I'm going to die. I think people need to go into the saying, I am going to find the right person who can help me, treat me, and give me the best quality of life that I can get. And so, yes, I think, I think you're a testament to it, right? You're 42 years. Come on. Yeah.
42.
You've been 40 what?
42 years with it.
Okay. Yeah. And that's longer than I've actually been practicing sarcoid. So there
Ah,
you
ah. uh,
go.
but yeah, and doctor, if I can dovetail on that and just with my own experience comment and with remission, the question about remission, in my own experience, yeah, the first 10 years was a challenge. Um, the next 20, 25 years, I had other things to worry about, raising three children, dealing with diabetes. Within the last few years, and I guess that's what I'll tell everybody, all of us here who are persons with sarcoidosis, it's a roller coaster. A chronic illness is a roller coaster. It's better than any amusement park you're ever going to go to. You know, and Abigail knows we talk about the spoon theory. We always put that up, the spoon theory. You know, um, some days you're not even going to remember you had sarcoidosis, and other days it's going to slam you right between the eyes, and that's when we go sarcoid. What is this? Um, and one of my favorite T-shirts. Everybody knows I love my T-shirts. One of my favorite T-shirts, and it's one of, all of us with sarcoidosis should wear. But you don't look sick. you know, try to look at somebody who has sarcoidosis and go, hmm, you know, how do I know? Can't tell. What interesting question, doctor, and I know I always find it interesting. Clinical trials. Are there clinical trials? I'm very curious about research on sarcoidosis. Do you know of clinical trials or what kind of research is going on that way?
Oh, I actually was just in touch with my colleague who's at Johns Hopkins, where they have a very active sarcoid center and they do a lot of research. And she sent me 4 slides on research that's going on. And I think we unfortunately are not going to have time to go through those slides. And I wouldn't be able to even answer the first question about these studies, but there are clinical trials going on at all the major medical centers that are involved with sarcoid for sure. And I have a little sneaky thing which we can put into the chat if I don't know how to type it into the chat from my end, but it's called clinicaltrials.gov. So on the web, you can literally put in clinicaltrials.gov and that will spew out pages, and you type in your search thing, you want to type in sarcoidosis, and you will see a gazillion trials that are ongoing. Now, some of them are therapeutic, meaning medication related. Some of them are going to be these cardiac studies that I was talking about before, like the PET scan, the MRIs, and then some of them may be questionnaires, like making, validating questionnaires. Because for doctors, a lot of times we don't really know, like, what questions to ask that are meaningful in terms of making people better. Yes, you found it, Abby. You are amazing.
Thank you,
Yeah,
Abigail.
yeah.
Yeah,
So anyway,
we've
this
got.
is not, this is, if you could stop right there, just, oh, no, if you want to go back to that for one quick second, because if people are going to start looking at this, they need to know how to kind of interpret it. So right there is this cardiac sarcoidosis randomized trial. There, it says recruiting. The green button says recruiting. That's actually key, because then you want to actually, then you can go into, you click on the cardiac sarcoidosis part, and it will take you to all the information where they have study centers, and what they're looking for. So if you keep going down, it'll say when did the study start, and then it'll have what they're doing, what the doses are that they're looking at. This one is a prednisone methotrexate, and then they'll tell you, there'll be like inclusion criterias and things like that. And so you can say, oh, this looks like, my friend next door could do this, or I could do this. So anyway, this is our science website. This is like where researchers go to look at stuff. So this one, for example, will say eligibility. Age is eligible. You have to be 18. All sexes are welcome. We do not accept healthy volunteers. So that's, if you guys are really interested, that's a great place to find some resources.
And sometimes clinical trials will pay you a stipend. So
Sometimes they do. Sometimes
yeah.
they do. Yeah.
It's wonderful. Let's change the directions a little bit because I think it's kind of fun here. We have according to what I'm seeing, we've got 36 attendees, but we've as Abigail had people put in where they're from. We are international tonight. We're not only North America, but I noticed New Zealand. So good morning, New Zealand. Good Friday morning, New Zealand. It's breakfast time out in New Zealand. But Dr. Carr, let's go with that. One of the questions about travel. I know my wife and I travel. Our children live in Colorado, Montana, and Oregon, and not only travel, but in that same conversation. And I know in our support group we find it. Boy, does elevation mess with sarcoidosis. Abigail knows that. She lives out in Grand Junction. Abigail knows where my children are in the high in the mountains, and I've actually met Pat and I've met Abigail face to face. When I get in the Rocky Mountains, watch out. So travel, both air travel, ground travel. What kind of things can you tell us about traveling with sarcoidosis, doctor?
Well, I used to live in Salt Lake City, Utah. So we are at 4,200 feet at in the basin. So yeah, I don't know, honestly, that any of my patients that were from that area had worse sarcoid or anything that I've seen here on the East Coast where I am now. At sea level. So I don't think that. I think the problem is for people who are not living, sorry, people who are not actually living at altitude. When you go from sea level to altitude, that can cause a big problem for even healthy people, right? Of people, like, you get off the plane, you have a headache and that kind of thing. So throw on top of it that you've now got some lung involvement, it will actually kind of declare itself a little bit more if you're at altitude. And that just has to do with the pressure of oxygen and everything else. There's less oxygen up there, even though it's not that high. So going from sea level straight to altitude can really be a problem for people. You have to do it gradually over time. So if you drive there, you're less likely to have as many problems. And also, I mean, hopefully everybody knows that athletes will train at high altitude because it will give them better endurance and stamina when they come down to sea level. So that is generally what I think probably impacts people the most. Again, for when I was in Utah, I probably had 500 patients with sarcoid who did not have any worse disease than what I see here. So that's that. Airplanes. So I am not an aviation specialist. However, what I do believe is that they pressurize cabins between 5,000 and 8,000 feet in general. So when you get on an airplane, it's mimicking being at the altitude. So it certainly will increase people's risks for having complications. So, you've heard of stories of people, saying, "Oh my gosh, is there a doctor on board?" And that you can see anything and everything on the plane. It can put stress on a system that is already fragile. So again, the only time I typically counsel my sarcoid patients is if they're on oxygen already, or if they're teetering on the edge of oxygen, then they may need oxygen in the air. And the way that we test for that is that we actually do what's called an arterial blood gas, where we draw blood from the wrist in the artery system so that we can actually look at the exact oxygen content of the blood. And if it's low at sea level, even though it's not low enough to require oxygen at sea level, we have a number cutoff that we know would be potentially at risk for altitude. So, if you're going to fly and go to Colorado and you already have issues at sea level, then you should be prepared to take some oxygen with you or get some oxygen so that you can be safe where you go and still have a good time.
And great, Dr. Carr, that gives me a perfect segue to the next one. Is oxygen supplement, not only traveling, but is oxygen supplement a realistic, way to help enhance or help deal with sarcoidosis? Do we prescribe that very often?
Only in situations where people need it. Having extra oxygen on board, actually, if you're trying to give yourself more oxygen than you really need, can actually be dangerous. So we don't do that. It actually can have detrimental effects. So we have sort of the sweet spot, which is, sort of what normal healthy lungs don't need oxygen. So we don't do that. If you are that 6-minute walk test, when you're walking, you drop your oxygen levels, then you need oxygen. Most of the time, if people need oxygen during the day, they need it at nighttime as well. Most normal, healthy people, when they're sleeping, they will drop their oxygen levels a bit, but never into a crazy zone or scary. So we, do sort of automatically assume that somebody who has issues during the day would have it at night. Sleeping mechanics are all different when we're sleeping and things like that. Respiratory mechanics are different when we're sleeping. So yes, if you do need oxygen, it will improve your stamina. It will improve your memory, because we know that low oxygen leads to limited, slowed reflexes. It can lead to memory loss. It can lead to then the really bad stuff that comes with not having enough oxygen, which is heart failure on a good day and what we call sudden death, where your heart just stops. You're at the grocery store and it just stops, and people don't have oxygen to give you, which is what you need, and we can't fix that. So yeah, we never really encourage people who need oxygen not to use it. But when patients are very, very hesitant about oxygen, and I get that, right? Like it is a flat out label. I'm wearing oxygen, and everybody says, "Oh, you're an invalid now." But it can really improve people's quality of life significantly. So hopefully, if you do need it, that you're able to overcome all that and get it.
Thank you. That's interesting, and it's after 42 years, a question I've always had. I'll see if I can avoid that. One of the fun questions on here, and it's a little more abstract, and Abigail knows it relates to what we all get. A question of, my daughter has sarcoidosis. I have a T-shirt and a window sticker. What's the best way to respond to people to ask what SAR, and that's our sarcoidosis? Doctor, that's pretty abstract, but what's your experience? I know after 42 years, it becomes a real learning opportunity, but explaining sarcoidosis, wow.
Yeah. Wow. So when we started off by saying, is it an autoimmune disease? Generally speaking, if I have a 20-second elevator pitch, I will say that it's an autoimmune disease. If I have 10 minutes to explain, then I will actually be able to explain a lot more in detail. But I think generally speaking, it's safe to say that, it is a immune system issue where you're kind of attacking itself, hence the autoimmune piece. And I think that's really the simplest way to describe it to people. The more fun way that I enjoy describing it is trying to find an analogy that works with people. So I live in Maryland, and apparently now Maryland likes oysters, right? Or maybe, I know we like crabs, but so, an oyster makes a pearl because the grain of sand gets inside the oyster shell. The oyster is irritated by it, and it spins a cocoon around that grain of sand. And that is a perfect, beautiful analogy for what a sarcoid granuloma is, right? So the thing I say all the time is, we just don't know what that grain of sand is for the human. And the granulomas that the human makes are not going to be these pretty little pearls, right? They're generally only seen under a microscope, but sometimes you'll see people who I've seen them like in tattoos, where they get little lumps along their tattoos, like little bumps. And those are granulomas that are basically forming in there. But generally speaking, unless you have it on your skin, it's nothing that anybody can see. And then the the body is spinning this cocoon, kind of trying to protect itself from something. And that is the immune system that's triggering that. And so, yeah, maybe that's a 2-minute pitch.
Yeah.
I haven't timed it.
And thank you. That's very great. And let me just note to folks, Abigail and I are certainly, and my wife Pat in the other room, we're monitoring the Q&A, we're monitoring the chat. We know that you've got a lot of questions in there, and we're certainly not ignoring them. We also had a lot of questions submitted beforehand, so be patient with us. We may not get to all of them here in our session. We're going to make sure we record all of the questions, both in the Q&A and the chat. Again, always take a look at the lifeandbreath.org website. There's been webinars, there's resources. Some of the questions you're asking may be covered in there, but just keep an eye on them. One that popped up, and we talked around a little bit, Doctor, and I know I'm interested, certainly. I've been, I had some liver things. Liver, spleen, what kind of things do we look at, beyond the pulmonary, beyond the lungs? I think liver and spleen seem to come up a lot. How are we impacting other organs? What kind of things happen?
So those granulomas get into any part in the body. They can get into everything. So very commonly we see sarcoid in the liver. We don't have a great blood test for sarcoid in the spleen, but if we start to see problems with our white blood cell count kind of thing, that may trigger, maybe it's a spleen involvement. But we see it in the liver, we see it in the kidneys, we see it, kidney stones, very, very common with people with sarcoid. And that's because of calcium creation in the body, because of the granulomas, and then that will trigger kidney stones. And then people also just actually have disease in the kidney. They have granulomas in the kidney. You get it in the brain, you can get it in the nerves, you can get it in the, like we said, the skin before, the eyes. People get sinus stuff, like terrible sinus congestion and things like that. That can be from it. I'm trying to think without missing any organs. I have a patient who has it in their colon, so that they get a lot of changes in their bowel habits all the time and things like that. Abdominal pain. It can pretty much affect everything. So, while we can't test for everything all the time, we certainly do test for the obvious ones. So the blood cell count looking, that'll also talk about the bone marrow, which is another place that can go. So your CBC, which is your white cell count, your hemoglobin, your platelets, we look at those. We usually get a comprehensive metabolic panel, or well, for me, that's what I get, because that has the kidney in it, that will have the liver in it, that'll have my calcium. So, we'll monitor those things to look for internal organ stuff. Sometimes when you get a cardiac PET, because you've had some reason to suspect and insurance companies will not pay for a cardiac PET unless you actually have real reason for it. So PET scan is not the way that we monitor or diagnose sarcoid. But if you do get a cardiac PET, it will light up wherever there is sarcoid. So that's actually sometimes a really, I'm very grateful when I get to get a PET scan for my patients, because it really kind of tells me where it shows up. So yeah, I hope that answered the question. I feel
It does. Thank you.
I rambled on. If I ramble on, you guys just have to cut me off.
No, we're not going to do that. I know we're certainly not going to get all of these questions in. We're getting near the top of the hour, but one question, and it's kind of a group. It's a very contemporary question, and I know this comes up in our support group too. Do you recommend? There's, we see it on television. Let's start with the obvious one. Do you recommend COVID, flu, RSV? What inoculations do you recommend? And are they or are they not? There's all kinds of myths about whether people with sarcoidosis should get any of these inoculations. Certainly COVID impacts it us because of the respiratory. What's your thoughts on the inoculations?
Wow. That is a great question. It is really, really tricky because, yes, part of first of all, I just hate this topic because it's so politicized in our country. And I'm just going to say that, right? So I'm going to really stick to the best science that I know. I definitely follow the CDC guidelines and recommendations. So you mentioned RSV. I have no real input on this, but the CDC is recommending for people over 60, all people. So it doesn't matter if you have sarcoid or not. They're recommending it for all people over 60. So, but for people specifically with lung disease, I do really worry about like what's the best way to protect yourself from actually getting one of these viruses or other infection that could potentially kill you, right? So, I know people are working so hard to maintain a good quality of life and maintain independence and things like that, that if they, won't take a vaccine that will actually has been proven over and over and over again to actually help reduce serious complications and death from a respiratory thing, I'm all in. So for me, flu shot every year, and the CDC says October. So I usually tell my patients sometime around mid-October is the time to get that, because it won't, it takes about 2 to 3 weeks before you're going to start to see immunity from it. None of these vaccines, whether it's flu or other, is going to prevent you from getting it. But what it will do is if you were to get it, it mitigates the symptoms. It makes them less severe, right? So that's all we can ask for, right? Because other than like putting yourself in a bubble or doing that, stay at home thing, you're going to be around other people and you're going to get sick. So it's the best thing to do is to really try to protect yourself in every way you can. So that's my thing about the flu for sure. COVID booster, they've just come out with a bivalent COVID booster for all of the COVID that we're seeing now. So I think that is extremely important. We are seeing way less severe disease than we used to. We have an outpatient treatment now that can be given for people who are high risk for progression to actually fatal disease. So, I think people are just in a much better place. And also we know what we need to do to protect ourselves. The pneumonia vaccine for people who have lung disease with the sarcoid should definitely get the pneumonia vaccine. The thing that comes up sometimes is when we talk about these autoimmune diseases that, and I put that in big quotation marks, that it can ramp up your immune system, right? Because that's what a vaccine does, is it makes your immune system kind of, turn on so that it can create a little army ready to go. And that can trigger some symptoms or make a flare or something like that. In my own practice of many, many patients, I've had one with whom that happened, but maybe it wasn't from the vaccine. Like that's not science, right? I can't say one person is, so I personally, based on the science and everything else, I recommend it strongly for all of my patients.
Great. Thank you, doctor. And again, just as a note, Pat and I may be a little more partial to it because if I stood on my roof on my tippy toes, I could see the Pfizer plant where the vaccine is being manufactured. And just as a personal experience, and again, as a person with sarcoidosis for a long time, when I did test positive for COVID, I had no symptoms. I was flabbergasted that I tested positive. I didn't even have a runny nose, and I tested positive twice in succession. So I was 10 days in isolation testing positive, and I will, not political, to me, it's scientific. I will firmly support, that vaccine that, again, I'm more vulnerable having sarcoidosis. And I was mad at that little thing. So yeah, thank you. CDC, I'm a firm believer in CDC, NIH, and some other time we'll have a conversation. One of my high school girlfriends is married to a guy named Francis Collins, so we keep in touch with Dr. Collins that way. Pretty incredible. Abigail, we've reached the top of the hour. There are many, many questions in the Q&A and in the chat. Everybody, we want to thank you for participating. Abigail, we're going to make sure we capture all this. We're going to do our best to address whatever we can. We certainly encourage you to join us on the second and fourth Thursday of the month at 8 p.m., and we'll keep some of this conversation going. Dr. Carr, it's certainly been a pleasure having an hour with you. Abigail, I'll let you close us up.
Yes, thank you, everyone. And I put it in the chat, but please email me at abigail@lifeandbreath.org if you have a question that we didn't get to. And we have several different experts that I can email and then try to get a response back to you. So please do that. Dr. Carr, thank you so much again. Dick, it was super great to have you here, just giving it from the patient perspective and what you're seeing. And so thank you both very much for coming out tonight.
It is my pleasure for sure. I really love the work that you guys do at Life and Breath for sarcoid patients. And Dick, I've heard so much about your support group. I think support groups are really, really helpful and important for patients who are living with sarcoid. And you know, it's just an honor. I'm sorry that we're not able to get to everybody's questions. And I appreciate that being invited. So.
Oh, thank you.
Thank you. And if I can give a closing note to everybody in participation, I certainly don't mean it to brag on it, but everybody, 42 years I've got in with this. It is survivable and it is livable. Back to our very opening question, Dr. Carr, normal life, my life's never going to be normal anyway, but yes, you can live and live happily with sarcoidosis. That's our message for tonight.
Yes, yes. All right. Thank you all. Have a good evening.
Good night. Thank you.